Greetings to all of our ACAM members, friends, and visitors. Today we have the pleasure and honor of hosting Dr. Duncan Ross and Dr. Avi Herskowitz on another eMedTalk. Today's session we'll be covering the COVID-19 updates as well as immune modulation with MSC Exosomes. The format for today will begin with an introduction from Dr. Herskowitz, as well as a brief presentation, the president of ACAM, followed by the feature presentation by Dr. Ross, and ultimately it will conclude with a question and answer section. Please submit your questions in the Q&A section or chat box to the right, and they'll be read aloud at the end. I'd like to introduce Dr. Avi Herskowitz as the president of the American College for Advancement in Medicine. He has been not only a wealth of resources, knowledge, and information, but also leadership during these turbulent times. He has an extensive background in cardiology, immunology, autoimmunity, and virology. His expertise and experience in those fields are extremely welcomed and sought after. So without further ado, Dr. Herskowitz.
Well, I wanted to first provide everyone with an update as to where we are today, because we all know that we're in dire times, and I wanted to put the current situation in the United States and more globally into perspective. I want to first start with a resource that I think everyone should look at. And right now, if you can see my screen, this I'll bring it up in the next slide. You'll see what is probably the best single analytic tool out there. It's called 91-divoc.com, but it normalizes all the data in this large database, and it normalizes things by population, which I'll explain why that is critical. But if you can sort of see that, I'll show it to you in just a minute again. And the other resource I wanted everyone to be familiar with is both on ACAM's website, acam.org, as well as my own website, which is anataramedicine.com. When you get there and you look at the coronavirus updates, you'll see that I posted yesterday a protection protocol that includes a lot of the sort of the routine things that we could do to protect ourselves, either on the prevention side or on the treatment side. But those are just tools that I wanted to reflect on. But I wanted to now go into mode in terms of putting what we have in perspective. So we know that we roughly have 80,000 some odd deaths in the world and some 12,300 deaths in the United States. But let's look at it in perspective. This is the top global causes of death in 2016 from the WHO. And I think some of us have already seen these data and show that deaths from tuberculosis, deaths from diarrheal disease, as two big infectious disorders, are in the 1.5 million to 2 million range. There's also lower respiratory infections, which primarily includes babies in the developing world, over 2.5 million, almost 3 million, and the same goes for COPD. So we're talking about orders of magnitude more issues that are happening globally on an annual basis, even from infectious diseases. We probably hit the 30 to 40,000 range for influenza virus annually in the United States. And so when you look at the data in the United States, we have 2.8 million deaths. And the number to remember here is something like rounded off to 900 deaths per 100,000 population. So right now we're at 3.7 per 100,000 deaths in the United States from coronavirus. So we're at 1/300th of this. So if we were to magnify this to three times the current number of deaths in the United States at 1% of our annual death rate, we would still reach 30,000 deaths. And there are roughly 600,000 deaths annually from heart disease and cancer, respectively. So a total of 1.2 million per year. And right now we're at, we're again 1/20th, we're at 1/40th or 1/50th of that range. So just to put it in perspective, and I think most of us on this webinar already are beginning to understand this over time. So when you look at the leading causes of death, here they are. But when you look at influenza and pneumonia, it's roughly 4 or 5 times our current death rate from coronavirus annually. So we're used to seeing these curves here. These curves are the ominous looking ones where the top one is Italy, Spain, and somewhere, this is as of 2 days ago when we were at 9,600, we're at over 12,000 now, and you say, listen, this looks ominous, and I don't know where this curve is going to eventually go. But when you look at it from a population perspective, when you look at it per capita, you realize that when we had 10.9 thousand deaths, I think it was yesterday, when we redid the numbers, you realize that the death per population is 1 in 30,000, which is roughly 8 or 9 times the less of a death rate than in Italy and Spain, and 1/3 of it in France. Roughly similarly to the UK and Iran, but slightly less toxic in the United States. So again, when you're looking at the data, and that's the reason I showed you that website before, you can play around and you can normalize to the population. So basically, we have a situation where we are driven in the United States by the top 5 or 10 states. So we know that ground zero is New York, and that's where the deaths are highest. It's 1 in every 4,100 some odd people in New York State, sorry. And then in New York, it's a little bit higher, 1 in 3,000. But the majority, 2/3 of all mortality in the United States are from the top 5 states, and then 80% are in the top 10 states. So again, it's a regional crisis as well as a national crisis, as well as a global crisis. But when you look at the numbers and you try to fathom these deaths per population, in California, for example, it's 1 in 100,000. So it's 25 times relative to population, 25 times less severe in California than in New York State, as the numbers sit today. And we don't know where the numbers are going exactly, but we can follow those trends on our own. So the purpose of today is to go deeply into immunomodulation, and that's why I invited my esteemed colleague, Dr. Duncan Ross, who's an immunologist, and we can talk about the principles of immune modulation. But again, on that website, and soon to be on ACAM's website again, will be a primer on basic things you should do, like vitamin D, vitamin C, vitamin A, and they're all listed here. I'm not going to get into these in detail at all today because we're going to focus on the role of master regulators of immunity, and that will be, in this case, the exosomes, as an example of how to masterfully and more comprehensively modulate our immune systems. But we have today also drugs to talk about that it will be subjects for another webinar in the future, the hydroxychloroquine and zithromax, which are largely being held for inpatients in ICUs, and antivirals, which are being studied in clinical trials throughout the world in the United States. I'll let Dr. Ross talk about his philosophy and his company's efforts to study the role of exosomes as regulators in this type of situation, particularly for inpatient care when you're really, really ill. But I also want to say that there are what I call biological modifiers that are also being studied over time, and these are cytokine blockers. These are anti-inflammatory signaling blockers, so that will lead to a less inflammatory state. The whole idea here is that COVID-19 will allow us to study the role of the immune system and to analyze how you can modulate your cells down to from a hyperinflammatory state down to a state that's more steady state. So again, these are the resources I wanted to share with you, and then I'll give the mic, so to speak, over to Dr. Ross, who will speak to specific pathways that he knows are important and pivotal in being able to modulate downward from a hyperinflammatory state. And then we'll go into Q&A after his much learned presentation. So, Jordan, if you can give the mic over back to Dr. Ross, I would appreciate it.
We're going to discuss exosomes today, which I've been working on since about 2014. Certainly the idea of vesicles that could move between cells had been known before that, but we didn't know their function. We thought that they were trash of cells and that they were secreted to get bad proteins or misfolded proteins out of a cell. We also knew that certain immune markers were passing back and forth between cells, but you could think of it from my point of view before I really understood a vesicle, that two cells can bump into each other and their cell membrane is basically like olive oil. So you can imagine if two bubbles of olive oil run into each other, they become one. And that does happen often. Two cells can become one. So I felt that, these immune particles are being picked up in that fashion. I didn't understand that in reality, you can think of it, and I don't watch football every Sunday, but I like this analogy, that you have a quarterback and you have a receiver, and they want to pass information between each other. So one basically throws it to the other one and doesn't need to be exactly in the neighborhood of the first cell. So it can not only distribute this information to a cell that's next to it, but to a cell that is far away in the body. Let's say your spleen recognizes inflammation and the inflammation is happening in your knee. You can send an anti-inflammatory message to that knee. And in fact, the body is anti-inflammatory all the time. And it's really hard to wrap your mind around that, how anti-inflammatory it is. Every cell secretes anti-inflammatory factors pretty much. Some secrete more than the other. Even a macrophage that becomes the center of the immune response can secrete anti-inflammatory factors before it's turned on. So the way I've been promoting or approaching inflammation with Kimera Labs up until this time has been in obtaining those factors from cells, not the cells themselves, and using those factors to suppress inflammation in various types of diseases. The first disease I really worked on was COPD. COPD was, I started with an IRB approved trial using stromal vascular fraction, which are cells taken from your fat. Then I progressed to expanding those cells to have more of the mesenchymal stem cell, which for the purpose of this talk, we'll think of as the center of your body, the director of your body. And then over time, I started to see that older patients' cells were not quite as functional as a younger patient's cell. So we started to go to younger and younger cells, and I've now ended up on placental mesenchymal stem cells. So I don't actually take a placenta, grind it up, and use the cells. I create a master cell bank from a placenta. And I did that before this COVID outbreak happened. It was over a year ago. So then you have a master cell bank and you have a working cell bank. And so every month I take a cell line out of the working cell bank, I use it for 1 month, and then I throw it out in order to constantly have a fresh a refresh of cells, basically. Okay, so the exosome mechanism is, if you think of your cells, or the cells of your immune system, you have B cells, you have macrophages, you have T cells, and you have B cells. Or you have two types of T cells. You have a CD8 T cell, a CD4 T cell, and in fact, a Th17 T cell. But all of these need to be off in order to not cause arthritis in a normal, non-inflamed state. So, but your macrophages need to be surveilling the system to make sure that a bacteria hasn't accessed the body. So your mesenchymal stem cells secrete a number of immunomodulating factors, and we try not to call them anti-inflammatory factors because they are indeed immunomodulating. They both want to keep inflammation from happening, but they also want to keep your monocytes in a slow pace turning into macrophages and dendritic cells that can then surveil the organism and try to find particles like viral particles. So these macrophages and monocytes are slowly surveilling the scene. A viral particle comes into the area. They phagocytose that viral particle, and then they start to break it down in an endosome through lysozymes. Once that happens, you have toll-like receptors that are inside of that particle, and they see the virus, and then they start to upregulate the antiviral machinery. And what does that mean? Well, it means it breaks down that virus, but B, it means that the cell starts to secrete exosomes that tell other cells in the body that there's a virus around. Those cells now start to upregulate their antiviral machinery. CD8 T killer cells and CD4 helper cells start to become inflamed. They start what's called a cytokine storm. B cells, I don't know if you know this, but B cells can uptake antigen as well. So B cells will now uptake viral antigens and start to release antibodies to that virus. And then those antibodies will ultimately control the virus after CD8 T cells have killed whatever cell is infected with the virus. So over time, you start to win your war against the virus, but the inflammation doesn't stop. Because in the case of this particular virus, you have a number of ACE2 epitopes that the virus can get into. Those epitopes are present in the lung and in the gut. So that's why many of these patients have diarrhea. And as you know, many of these patients have mostly what we're discussing today, which is acute respiratory distress syndrome. So the exosomes that we're going to talk about today are coming again from a stable state patient. So that means they're going to be anti-inflammatory and they're going to allow continued phagocytosis. And this is going to be important in the case of ARDS in a minute, a few slides from now. So what do the exosomes contain? The exosomes are secretions from a mesenchymal stem cell. That means they contain proteins, they contain messenger RNA, and they contain microRNA. The proteins are important because they will immediately downregulate any inflammation. And we've seen this over the 30,000 patients that we've treated since 2014. The messenger RNA and the microRNA have other uses. The messenger RNA can make anti-inflammatory genes for a long period of time, anti-inflammatory proteins, for the order of days, whereas proteins will only be functional for an order of hours. And some microRNA can impede viral replication, but that is a loaded question, as if you ask yourself, why do some people, even young people, have a worse result when encountering a virus than others? Well, because the way viruses work is you can uptake 2 viral particles, which your body will easily clear, or imagine someone sneezed directly or coughed directly in your face. You'll uptake tens of thousands of viral particles. The more viral particles you get, the more difficult it's going to be for you to beat the virus. That's why a husband and wife can get the exact same virus. The husband dies and the wife didn't, which is very, very sad. So some of the things that these exosomes from MSC have, and remember I said that every cell secretes exosomes. We specifically focus on mesenchymal stem cells because they are very anti-inflammatory, and as I said, they control the growth of your body. So they instantiate growth in a way that another anti-inflammatory cell might not do. If you think about it, when a cell is an organism is growing, these cells are coming from the mesenchyme, from the center of the body. That's why we call them mesenchymal. So they're secreting growth instantiating proteins like fibroblast growth factor, hepatocyte growth factor. They're secreting pro-angiogenic factors like VEGF, immunomodulatory factors like TGF-beta3, and this is the one that I usually focus on in my talks because TGF-beta3 will turn an inflammatory CD4 T cell into a non-inflammatory regulatory T cell just by adding that protein to a dish in vitro. That has to be done though that can be done by a macrophage. Macrophages, when changed into an anti-inflammatory macrophages, can turn the inflammatory T cells that are causing all this problem in ARDS into a non-inflammatory T cell. And so we need the function of the macrophage for that to happen. We're going to look in a second at some different therapies being used right now, and they can impede the ability to turn off the immune system, which is very scary, and we've seen it happen already. Exosomes from MSC are also anti-apoptotic. The issues we're having in ARDS is that you have this cascade of cells dying, and when they die, they secrete death particles into the environment of the alveoli, which are already filled with fluid. And so it's sort of a self-fulfilling prophecy there, that once some of the cells have died from the initial viral insult, the cells don't stop dying even though the virus is gone. It's called a cytokine storm, and it occurs in graft versus host disease all the time. That was my background. That's what my dissertation was on. We understand very well how to suppress that. And in fact, one of the reasons I used mesenchymal stem cells is because a company called Osiris in 2009 was using mesenchymal stem cells to suppress graft versus host disease. They also are tumor suppressive, which is another talk for another time. So again, they're immune regulatory. They can reduce inflammatory mediators like IL-1 beta, TNF alpha, interferon gamma, IL-6, and IL-8. If you want to hear an interesting anecdote, which may be scary to you, one of the issues we're having in this country is that when a therapy is working, we don't have a real way to tell, especially if a patient is on a ventilator. Yes, you can reduce the necessity for the use of that ventilator, but what we've seen happening in the clinic right now is there's so much confusion between what to use that the patient may be improving, you don't know it, and so you add another type of therapy or medication which is going to be antithetical to the function of that first therapy. So as I mentioned before, if we can use TGF-beta3 to stop the inflammation, how do you track it? Well, in a trial that we're beginning in Germany at the University of Ulm, there is a machine made by Siemens. It's called an Immunology 1000, and it can give you back a cytokine profile of these that you see on the screen right now within 30 minutes. So they have the ability to test these patients twice a day and see if their intervention has worked. It really strikes me that in most hospitals working right now, you have sort of legacy type tests such as white blood cell count or CRP protein, which these are not immediate inflammatory markers. So we don't really have a way to test whether or not the interventions are working. So one of the things that I'm trying to do, my new little crusade, is to try to get this Imulite machine into more hospitals in the US. Sadly, Siemens had already decided to stop making the machine because there was no uptake in the United States. So now we have to try even harder to get that going. We do have some good news that occurred today that Thomas Jefferson University is also going to begin our clinical trial, just like Germany. And I'm going to try to get that machine into the hospital in order to get these markers. What we saw in the first patient we treated was that the patient was improving over a few days, and then hydroxychloroquine was added. And that hydroxychloroquine interferes with that macrophage axis that I was just talking about. We need the macrophages to function. We just need them to not be inflammatory, and that's what the exosomes do. If you take the macrophages out of the equation, you won't be able to turn off the immune system. So again, then what's the difference there? So the difference is that when you are in the antiviral state, you have an M1 macrophage, which is required. This is why you wouldn't prophylactically take hydrochloroquine. Hydrochloroquine is probably appropriate for people with a low-level infection. If you have a very high-level viral load and you give hydroxychloroquine, you probably won't resolve from that. Even worse is if you take hydroxychloroquine, it has a 22-day half-life. That means that if you make a mistake on the therapy, the hydroxychloroquine is going to interfere with any other therapy, including mine, for a period of up to 3 months. What we want to do is take the M1 macrophage and turn it into an M2 macrophage, which is an anti-inflammatory macrophage. It will start to secrete TGF-beta3, IL-10, PDG, and other anti-inflammatory cytokines, but it will also dock with the inflammatory CD4 T cells and turn them into non-inflammatory CD4 T cells. It does that through the T cell receptor and the MHC class II that's on the surface of the macrophage. When that docking happens, it's occurring because there's a viral antigen in here, in this MHC2, that binds exactly the T cells that are specific for the virus. So when they come into close contact, this macrophage can turn off this T cell. Again, I'm repeating this to try to demonstrate the necessity for that macrophage. You just don't want it to be an inflammatory macrophage. So the name of that T cell that's really causing the inflammation is a CD4 T cell. The one that's the killer T cell is a CD8 cytotoxic T cell. So if we can convert the M1 to M2, we can stop the inflammation causing ARDS. There are also microRNA that these are very small RNA between the order of 15 nucleotides to 100 nucleotides, which can interfere with inflammatory processes. So this is what the COVID looks like. The size of it is about the size of an exosome. In my talks for the last few years, I've been saying that viruses, what came first, the chicken or the egg, the virus or the exosome? Viruses are fancy exosomes. So many of the things that we use to study exosomes, we can use to study this. For instance, the D-Storm microscope we have in the lab could see the COVID virus. It's very contagious because it has an S protein on its surface that, as I said, binds to ACE2. What we're finding, I heard somebody say on I try not to watch CNN every day, all day, it's depressing, but some of the emergency physicians who are on there said some interesting things. One said that most of the people we have in the ICU took ibuprofen. So what ibuprofen does is it binds the ACE2 epitope, but when you do that, it's just like using an antiperspirant with aluminum in it. You'll stop sweating immediately, but over time, your body will start to upregulate these sweat glands such that when you stop using the aluminum, you have more sweat glands and you sweat more. That's what's happening in patients that use ibuprofen. So try to stay away from that. And it's a natural reaction. You have a fever, you take ibuprofen. Suddenly you get worse. And that's what we saw. So it is slightly similar to the previous SARS virus that came out. It's the same type of virus. It's called a coronavirus. It stays on surfaces for quite a long period of time, which interestingly is one of the problems. I live in Florida, in Miami-Dade. One of the issues we have is that everybody ran out of New York to what's normally been called the 6th borough, and now we have quite a lot of infections. The bright side is that down here in the heat, the virus isn't going to persist on surfaces quite as long as it would up in New York. For instance, I had my car brought back to me yesterday. I haven't gotten in that car for 2 or 3 days to allow the heat to maybe denature whatever proteins are in there. So the problem is coming from infection of lung epithelial cells, and we have this again called a cytokine storm, which is happening. Now that we're talking about cytokine storm, and not to go off topic, I've heard I've never been involved with ozone therapies. But I wanted to explain why they are anti-inflammatory, because there is something called extracorporeal photophoresis that's used in graft versus host disease all the time, and it's the same theory as ozone. If you take blood out of the patient and you kill it, if you break everything apart into what's called necrotic cell death, and that's done with light in extracorporeal photophoresis, the body notices the inflammation and upregulates the regulatory T cells. The same regulatory T cells that we are instantiating the conversion of using our exosomes. So that's why that therapy works, just in case you're interested in that. So what are the signs of COVID? One is fever, just like any other virus you get. There's a dry cough. There's a loss of smell. There's headache. There's back pain, nausea, abdominal discomfort with diarrhea, as I mentioned before, because there's a number of ACE receptors in the gut, anorexia, and fatigue. I'd like to say that none of these are scary. I mean, these are what you want to occur if you're going to fight a virus. We have 2 things going on here. There's the initial infection that we want to get through, which takes about 1 to 2 weeks. And there is the dangerous post-infection, 3 to 4 week out cytokine storm that we'd like to stop, the sepsis, which is resulting in a pneumonia. I would not panic if I had these symptoms. It would make me feel like, yes, I have the virus, but I'm also fighting it. When I would panic is when I start to have trouble breathing, and we'll discuss that in a minute. So the mortality rate's about 2%. Again, it's more severe in patients with COPD. So this is what the alveoli look like when you have acute respiratory distress syndrome at that 4-week period. The lungs are filled with liquid and debris. But the cells that take that up and clear that are the alveolar macrophages. So you can have that argument that if you use hydroxychloroquine, you stop the phagocytosis of this macrophage, you're not going to be able to clear that. It's going to take you longer to resolve that infection. So again, HCQ is something for a specific level of infection, not for all infection. So the rationale for the exosomes, we're going to immunomodulate those macrophages. We're going to turn them off. We're going to turn them into an M2 phenotype, but we still want them eating whatever's in the environment. So that is an important consideration. So our clinical study design, we are trying to find patients that have not previously received HCQ, although that's very difficult since everybody is using it so quickly. The trial in Germany is going to preclude the inclusion of those patients that have used HCQ. I have yet to discuss what we're going to do here with Thomas Jefferson. We're investigating safety and efficacy, but also the ability to increase pulmonary function. These exosomes will be applied intravenously, and the endpoints will be safety and survival of COVID-19 patients at 14 days. We'll be looking at SpO2, heart rate, and other markers. Again, the respiratory support is an interesting question because a PEEP allows the alveoli to stay open, but these patients are so weak that we're finding that in some cases they're rupturing the alveoli with too high of a PEEP. So it's a very dangerous marker right there, or treatment protocol. So we have hydroxychloroquine, which I explained stops the macrophage from working, stops from phagocytosing, stops it from presenting antigen on its surface. We have the tocilizumab, which is an anti-IL-6 antibody, which again it's an IL-6 receptor inhibitor. So it's going to slow the phagocytosis of macrophages again. And a number of patients are suffering from acute bacterial pneumonia, which is why the immediate ability to look at inflammatory cytokines, like using that Siemens machine, is so important. And it would be wonderful to be able to have those. I'm actually getting a list of every hospital that has that in the United States. So right now, what are we functioning under? We have already applied to the FDA under the Emergency COVID Therapeutics Act. We received a reply back that they are triaging our application, and it's number 441. But for providers out there, there has been a suspension of tort by the in the Federal Register. You can read that, stating that a provider can't be sued or held liable at this moment for attempting to provide medical care. Certainly, this is a wartime sort of a time that we're in, and any modality that may function is fair game, I believe. I'm sure you've all heard of Rudy Giuliani pushing stem cells. Well, that's the same thought process. I used to use stem cells as well. This is just an extension of that science, which is taking what the stem cells are secreting and using that in a controlled, sterile, and qualified fashion, rather than using cells that may be contaminated that you haven't fully qualified. But our product has been fully qualified for application to the FDA. The data was already finished. We just hadn't pressed the send button, but COVID has accelerated that for us. So it does exclude willful misconduct, though, but I don't think we're speaking in that in those terms. Again, these are the types of things we needed to do for our IND application anyway, and these are the trial sites that we're working with right now. The importance of this is that we have a friend and colleague that we've worked with for a number of years. He is a physician that is well versed in regenerative medicine. He had his cells expanded. He also has used our exosomes for years, and when he was intubated, his wife requested the use of his autologous cells or exosomes, and regardless of whether there's a right to try law or not, the hospital denied his request. So if you're going to make these types of healthcare decisions, you're going to need to make them yourselves and before you enter the hospital. That's why that thought process of whether if you have regular fever symptoms, not a time to panic. That's what you're looking for. But if you're starting to have trouble breathing or respiratory symptoms, that's a time when you may want to treat a patient or be treated to stop that inflammation if it's 2 weeks past the infection point. So these are some resources you can go to, exosomes.com. Not that hard to remember, and we'll be doing some more webinars over the next couple weeks. Dr. Herskowitz.
Thank you, Duncan. I want to bring it up a notch in terms of the level. So thank you for that, and I think Kimera will hopefully lead the United States in how to address the most severe set of complications with our ARDS. Now, I do want to elevate the conversation and say a few things. Firstly, the reason I, as ACAM president, wanted you to give your lecture today is to have folks understand that the science of repair and the science of modulating the immune system is now being useful in this viral epidemic, but the science is the same. The science is the same argument as to why you would use exosomes or MSCs for health and aging purposes, for example. But in this case, it's useful as a tool to mitigate cytokine storm, but it is also useful for each and every one of us to consider on our own and for our patients. But I do want to remind everyone that the high-risk groups here are the 70 and over group and 80 and over group. They're the ones that are the most likely to get the severe complications, albeit there are examples of younger folks without comorbid conditions. But the average person that we're seeing in the ICU is above the age of 70 and then has multiple comorbid states like hypertension, diabetes, cardiovascular disease, and COPD and cancer. Those are the top 5. And so when you have people with existing pathology is the point that then become tenuous and need as many options as possible, including exosomes. I will say that Dr. Ross is not a clinician, and I would say that those of us that are treating mild and moderate and sometimes moderately severe cases have not seen the trend that he talked about with ibuprofen, and have seen generally good results with hydroxychloroquine and zithromax. So those things need to be formally tested, and we understand why hydroxychloroquine is going to be an exclusion criteria for this type of therapy, but for ARDS. But for the average person, the problem is not whether or not it's a coherent strategy for early and mild and moderate disease. It's because we just don't have access to it anymore. So the government is appropriately hoarding large volumes of it in order to treat inpatients throughout the country. We do have IV vitamin C, which is now being used in New York hospitals in very low doses, 1.5 grams. And the patients right now in my center that are having IV vitamin C are getting 20 grams, but it's 1.5 grams given every 6 to 8 hours, and hopefully that will help certain patients not require intubation. Ozone was a good presentation by Dr. Ross. I want to thank him for that, because it does intersect with the goodnesses of exosomes and so on. But if we now sort of take the idea that our main goal as a society is to prevent patients from coming into critical care, and then once you're in critical care, to get you off of intubation as quickly as possible. So we commend Kimera for their work in this regard, and hopefully you'll get more ICU physicians to sign on board and use these very, very safe strategies with exosomes in the future. But hopefully this will train us in terms of the anti-inflammatory lifestyle and anti-inflammatory concepts going forward, because up to now, you could not get vitamin C in the US hospital. So now we'll learn certain lessons that we would normally not learn. So thank you again. So Jordan, you want to open it up to questions?
Yes, sir. We actually have quite a few questions in here. So first and foremost, does your study already have FDA approval in the form of an IND, like the recently announced NK cell study from Cellularity?
No, those cells from Cellularity were already FDA approved. Now, I did have a phone call yesterday with another group that has an FDA approved cell type, but we don't have any experience with that. Now, we also don't have any experience with the NK cells in a situation, in an inflammatory situation such as this. However, as I mentioned, we did file that emergency COVID therapeutics application. You could call it an emergency IND application last Wednesday. I got a reply from them on Friday. So hopefully in the next few days, we should get another reply from the FDA.
Beautiful. Next question is, could you please address the differences in studies being done right now on COVID-19 between stem cells and exosomes, specifically the argument that live, I believe pronounced mesenchymal stem cells have the advantage of responding to their environment and secreting more specified exosomes as opposed to healthy birth tissue created under a zero stress environment?
Well, remember, that's a good question. I don't use birth tissue. I use a cell type derived from birth tissue 8 weeks ago. This is how Humira or Botox works. Any antibody you get, you have to have a cell line that you have qualified over time. using a fresh tissue such as placenta would be irresponsible, right? That's A. B, the idea that MSCs persist and respond to their environment, that's what your MSCs do in your body, your MSCs. But when you take allogeneic MSCs and put them into an inflamed environment, they're going to immediately start expressing MHC class 2, which is going to have them rejected in a period of hours. So I don't think that there is any interaction with the environment going on there that's changing their secretory milieu. They probably do secrete for a short period of time when they get in. They secrete exosomes just like the exosomes which we are putting in, but they are not proliferating and immunomodulating based on the environment. Cells have in this type have never been found for more than a few hours after implantation in this type of an environment.
Right. I would add, I would agree with Dr. Ross that in a hyperinflammatory environment, I would rather use the types of cells that would not be considered in any way foreign, in this case, the vesicles, the exosomes. But there's long-standing arguments about which therapy is best for any given patient population, whether they're the whole cells or the exosomes in healthy or specific disease populations, but that's a different discussion. But for hyperinflammatory states, I would agree with Dr. Ross on this. Go ahead, Jordan.
Yes, sir. Next question. So how was the dose determined? The dose was in milligrams over kilograms. So roughly how many exosomes would that be?
That's 15 to 20 billion exosomes. Of course, we do it based on weight, so it would increase over that. I mean, we treated a 360-pound man with 20 billion, which would be less than you would expect, and he improved within 12 hours. So that was the first dosing we got. But we've been dosing. We've treated about 30,000 patients, and we pretty much understand the amount to give a 70-kilogram adult, which is about 15 billion exosomes.
All right. So another question, and it's going from. Are you recommending that doctors can use anything that may help regardless of FDA approval? And
I'm saying that physicians have always been able to pursue the practice of medicine. Again, as Dr. Herskowitz pointed out, I'm not a physician. That's why I never make treatment advice. Previously, saying that to use high-dose vitamin C as an anti-inflammatory would have been scoffed at, right? It was scoffed at from Salk for a number of times. Now it's being used all over the world. So I am not suggesting anything. I'm just saying that a physician as an artist has a better idea of what to do than in these kind of cases than many other types of people. Like even take curcumin. Curcumin isn't FDA approved, but certainly some people swear by its anti-inflammatory effects. That's all I know.
I think Jordan, my answer to that is no one in this webinar is going to be walking into the ICU and treating someone with exosomes. It's the idea behind it, and then it's the company's responsibility to seek as much regulatory advice and support as possible. But the concept is what's pivotal here, and we realize that ARDS will no longer be treated like in the olden days where they would just they have very, very limited options. So we're going to have a lot more options in the future because we will spell out the inflammatory cascade in ARDS patients, and then over time understand who gets better and who doesn't and why. So this is a tool, I thought, for ACAM members and other practitioners to understand the value of being anti-inflammatory in this, or immune modulatory, as Dr. Ross says, in this type of an environment, and make sure that we take those principles in our day-to-day life, because right now we're in the first wave, as we all know. Since we don't have a lot of testing going on anywhere in the country, I still can't tell patients where to get tested who are asymptomatic in San Francisco. Since we don't have testing and we don't have treatments, then how are we going to be able to allow the public to leave their homes? Based on what rational arguments? And so we're trying to get as much information out there as possible. The HCQ hydroxychloroquine and zithromax is being tested all over the world. Vitamin C is being tested all over the world. Then we have our supplement world, which I gave you the links to, which are rational. I agree with Dr. Ross. We don't have to get FDA approval for ordering or recommending vitamin D or zinc, but they should be tested in this environment as well, because they're just supplements.
And also, too, it's important to understand that the Spanish flu lasted for 2 years. There were 3 peaks, and the second peak was the most deadly. I could easily foresee us suppressing the number of infections up until winter, and then the disease really taking off. It's starting to take off again in Asia after going down to 0 new infections. So what we're doing right now is working within approved hospital environments within the ICU. That's what I came to discuss.
And
yeah, and
so,
again, I just want to offer a different perspective as a clinician, that right now we all know the history of Spanish flu, but there's no evidence for a true second wave in any of the Asian countries at this point. They have the much more likely explanation is they're repatriating their citizens from all over the world and getting small bursts of infections. But I can tell you, in the countries in Asia that I frequent and have many colleagues in, there are mild bumps, but life is normalizing in these countries fairly rapidly. So right now we don't know what's going to happen in the fall and the winter, and I think that is why we have to adjust our lifestyles going forward so that we're as strong as immunologically possible going into the next season if it happens.
and another question for you, Dr. Ross. So someone had experienced chest tightness for almost 3 weeks, and then they decided to nebulize some exosomes, and they felt that it helped. Would nebulizing be as effective as an IV, or could you discuss more on that?
Well, I've had a number of COPD patients nebulized in the past. In both those cases, you have fluid in the lungs, and when the patient's nebulized, they would often call and feel like they felt even more of a tightness. And the way we resolved that was by using an albuterol or other bronchodilator before usage, and then that went away. But the way I look at that is the Chinese are nebulizing exosomes in far smaller numbers than we are. The reason we were going with that IV approach is because we don't want to increase the amount of fluid. But certainly there's 2 sides to that argument. I think that the group that I worry about most is the COPD patients that are not infected right now but do have COPD. When they do become infected, they're going to have a very difficult time. So those are some that I would probably think about seeing your provider or nebulizing now. As a prophylaxis against inflammation, not as a prophylaxis against the virus.
And there's still quite a few questions, so I'm going to pick about 2 or 3 more of these questions. So one of the questions is, if HQ is so problematic, then why are we seeing positive clinical results?
I didn't say it was 100% problematic. I said that it's going to depend on the viral load when you use it. Dr. Herskowitz could expound on that.
Yeah, I agree. So we don't know. We have some small clinical trials, and when you go onto the website, you'll see there are 3, 4 different summaries of all the clinical trials that we've already posted. When you have small numbers of clinical studies done in China in particular that show that you can use it in an inpatient environment, and it has been considered to be overall effective. I think there's the scientific argument that it may block certain macrophage populations, and that's a coherent argument to make. But when we see people earlier on in the disease, or people that are high risk that are developing sore throat, cough, chest tightness, we have seen anecdotally seen very good results. So in that setting, before you develop what's called acute lung injury or leak or pulmonary or lung leak, you can apparently use it fairly safely. But again, this is not yet FDA approved for use out of the hospital at this point.
And second to last, so a lot of those symptoms remind me of Lyme disease. How would I know the difference? And with CRP levels high from the Lyme, how much should I consider being concerned with the CRP high?
Well, I'm not exactly sure how to answer that question. This is acute onset of flu-like syndrome, unlike the chronic presentation of Lyme. And the C-reactive protein patterns have not been elucidated here. As you know, it can be elevated or even normal with Lyme, but we use other measures for Lyme, which is C4A levels that are almost always elevated, and I doubt that those would be elevated in a viral situation as this. So I don't think that there is a tremendous overlap, and certainly in terms of shortness of breath, coughing, chest tightness with acute lung injury, it is not in the usual Lyme presentation.
And last question, will stem cell treatment ever be approved by the FDA so health insurance providers will cover those treatments? At the moment, they can be too costly for the average person to afford.
Well, I think there'll be a guidance. I think Dr. Ross could speak to this too, but there'll be a guidance coming in from FDA later on, as no later than December 2020, with regards to their new sets of regulations and how we'll be able to operate studying stem cells and exosomes going forward with INDs, these applications for new drugs, in this case biologics. But over time, as the studies emerge from specific indications, we will ultimately be able to, if allowed, we'll be able to study them and get them approved. And at that point, then they'll be able to be covered by insurance. That is not happening in the short term, although again, I think the COVID-19 pandemic will allow certain things to happen much faster than they would normally happen. So there may be a silver lining here.
There's definitely two sides to that coin. One is that the reason that we have all the data for the IND ready is because it needed to be applied for by November 2020. Now COVID has done two things. I'm sure that date will be pushed back. But secondly, it gives a patient population for many companies, like you said, Cellularity, other companies, to show safety in these populations that really have no other options. So when you're saying, are you using something that's not FDA approved, if somebody's days or minutes from dying, that sort of goes out the window, and it's that ICU doctor making that decision. But many companies like mine will be able to demonstrate safety in those situations, and then that demonstration of safety will aid the IND application, which will, down the road, and I think it's still years, cause stem cell therapies to be covered by insurance.
So yeah, Dr. Herskowitz, I think that pretty much wraps it up with our time. I just want to appreciate.
I wanted to say last words as ACAM president.
Yeah.
We want to thank Dr. Ross firstly for coming and sharing his expertise, and the more immunology we have now, the better. But also in terms of ACAM and how we will distribute information out to the public, we're going to be going online much more often, and once or twice a week we're going to have these types of updates and Q&A sessions. So I want all the members and all the folks that are on the line to pay attention to the ACAM and the ACAM email. So we'll give you up-to-date information, and then I'll get the slides off to the central admin group in ACAM, and you could send it off to the email list. Okay.
Yes, sir. Thank you again,
Right.
Dr. Ross. Well, Dr. Herskowitz.
Thank you.
Bye.